I am Debnarayan Dutta. I am a radiation oncologist from Amrita Institute, Kochi, Kerala, India. So we are going to talk about role of radiosurgery in hepatocellular carcinoma with vascular invasion. This is a very interesting topic because there is not much data about this, the role of radiosurgery in this vascular invasion thing. Now, when we see the BCLC staging and treatment strategy as early as 2022, there is not much role of SBRT in advanced stage hepatocellular carcinoma, especially in the portal vein thrombosis. Most of the patients are treated with TKIs and now with immunotherapy, and the expected survival is 6 to 9 months. And the role of liver transplant in case of main portal vein thrombosis is less because even after downstaging, the role of liver transplant is not much there. So we need to see that what is the role of SBRT in portal vein thrombosis. And we have a prospective study where we are trying to evaluate the role of SBRT in portal vein thrombosis, trying to recanalize them. And I'm going to share that data with you. Now we know that portal vein thrombosis is classified by the PVT classification system, where the grade 4 is a complete obstruction of the main portal trunk, whereas grade 1 is only a portion of the portal vein branch is blocked. So depending on the extent of the portal vein thrombosis, the outcome may also depend, and our treatment strategies may also change accordingly. Now, with our prospective study, what we are going to talk. So, from the initial interim analysis, what we have published, and with that publications and the SBRT actually has been considered in our Indian National Association for Liver Consensus guidelines, and it's been included as a treatment strategy. Though the level of evidence is moderate because it is only a small patient cohort to start with, and there is no randomized data on that, but still there is a moderate evidence to treat with SBRT for portal vein thrombosis. So initially in 2021, we have published our interim data on the prospective study what we are doing on portal vein thrombosis treated with SBRT with CyberKnife. And initially, projection was to accrue around 116 patients. Interim analysis was done with 79 outpatients, and that from there, the guideline for treating SBRT came. But when we had done a follow-up of 210 patients accrued in the study, and 121 patients were eligible for analysis, we have done this assessment. And the tumor screening in 2017 to 22 was done, and then comprehensive assessment done, tumor board discussions was done, and then the patients were a contrast enhanced CT scan done, triple CT scan, put a fiducial, and the CT simulation was done, and done after the fiducial placement in a plain CT scan, which is the primary set, and the treatment execution was done. Now, about 181 patients who are accrued in the study, we have seen that majority of the patients are childhood A and B, and most of the patients are BP3 and 4, means the main portal vein or the main branch of the portal vein is involved. And when you see the response to RT, we are seeing that recanalization rate was 57%, and patients with no response was 42% of these patients. So majority of the patients, almost 60% of the patients, had response to the treatment. Now, when you have seen the outcome of those patients who are responders versus non-responders, so there's a significant difference in terms of outcome. So responders have around 16 months of mean overall survival, compared to only 12 months those patients who are 8 months, which are non-responders. So there is almost double the survival in these patients who are responders in this patient course, and there's a significant difference in terms of outcome in the p-value you can see. Now, in our patient cohort, around 67 patients were eligible who are responders, 49 were non-responders, and 16 patients were eligible but got accrued into study, and 23 patients were non-eligible because of various reasons, and the child could see and patient performance status not well. And when we have followed those patients for outcome, we have seen that those patients who are responders, the mean estimated overall survival is around 16 months compared to only 9 months in those patients who are non-responders. And those patients who are eligible but not treated with SBRT and treated TKIs, the median survival is around 5.6 months, which is like the literature what we see. And those patients who had a poor prognosis and poor performance status, the outcome was 2.3 months. That is also as per the standard literature review what we can see. So it shows that responders have the best outcome. Even those patients who are non-responders but treated with SBRT have a better response than those patients who are eligible but not treated with SBRT. Now, this is one of the best possible data available because it is very difficult to do a randomized data. It is a prospective data with a arm where eligible but not being treated. It can be compared at the control arm being treated with TKIs compared to those patients who are responders and non-responders. And you can see patients who have been responders have a significant benefit in terms of survival compared to those patients who are eligible but not treated with SBRT. Now, recently we have updated our data, and around 540 patients were screened, and about 96 patients were evaluable for assessments. We have seen that mean responders, the mean overall survival on responders is 18 months compared to 12 months in non-responders, and p-value is significant. So in the larger patient cohort also, responders has shown that there is a benefit in terms of overall survival in those patients who are responding with SBRT. Now, we have followed those patients who are more than a year followed and more than 2 years followed. So 75 of these patients who are more than a year followed, we have the data. We have seen that the responders at 1 year, 77% of the patients are responders who are more than a year follow-up, and 89% of the patients are more than 2 years, which have 2 years follow-up. So those patients who we are going to have a long-term follow-up, 1 year and 2 year above follow-up, they are almost 90% of the patients are responders. So response at 2 months post-treatment may be the indicator that these patients are going to have a expected long-term survival more than 2 years, and can be approached more aggressively, maybe with immunotherapy and a long-term systemic therapy may be considered in those patient cohort. On the other hand, when we see these patient cohort who are having a long-term follow-up, patients, only 11% of the patients are on immunotherapy, which have more than a year follow-up, and only 7%. So immunotherapy didn't change the long-term follow-up data in this patient cohort. And the change in the CHAT score is almost 50% of the patients have changed, and decline is only 13%, and 21% of the patients had decline in the CHAT score. So these patients where they have a long-term follow-up, the change in CHAT score is not significant. Only a small portion, 10 to 15% of the patients who have a decline in the CHAT score, whereas 80 to 85% of the patients maintain or improve their CHAT scores. So it is a response to radiation in the portal vein thrombus is a significant factor which improves the long-term survival. Neither the systemic therapy which is added, neither the change in the CHAT score, which may be responsible for having a long-term follow-up in this patient cohort. Now, when you see the rationale for treating portal vein thrombosis with SBRT, we know that portal vein is mostly supplied by the liver is mostly supplied by the portal vein. Almost 2/3 of the blood is supplied by the portal vein, and any portal vein thrombus can cause hypoxia and necrosis and supply to the liver is going to be affected, and recanalization actually can delay the decompensation and hence improve the overall survival. You can see that those patients who are recanalization have delayed in decompensation and improvement in survival, mostly because improved vascular supply in this patient cohort. We have seen in the literature that only TKIs, when you give lenvatinib or sorafenib, only 5% of the patients have reconversion, whereas when you do SBRT for the portal vein thrombosis, there is almost 50% of the patients who have reconversion, and that is the reason why when you do SBRT, there is a significant improvement in terms of delaying the decompensation and improve the survival compared to only TKIs. Now, how we treat portal vein thrombosis with SBRT? There's a CT simulation with contrast done, fiducial placement is done, usually 3 fiducials are placed, and post-fiducial contrast we do, image fusions are done, and contouring done in arterial phase, portal phase, and planned accordingly. We usually use the backlog for simulation and do the contrast CT. Usually double contrast is used to see appropriately, and triple phase CT scan is done, which has been fused. And there's a workflow for fiducial placement because that is important. We put 3 fiducials. Usually we put fiducials in a single prick technique, and there's a quality of the fiducial placement that's important, and we evaluate that. And usually try to put 3 fiducials equal distance to each other and can be seen appropriately. We have a parameters to see the accuracy of fiducial placement based on the number of fiducials, distance between the fiducials, the angle between the fiducials, and any kind of unexpected events that's happened after the fiducial placement. And the score of 14 to 15 is called very good, whereas 6 to 7 is poor. And we have seen that majority of the patients have a good or very good fiducial placement in our series. Now, recovery time is also important after the fiducial placement, which has been seen the standard grading system for recovery, and the migration is also evaluated as per the migration scoring system. Pain score is evaluated by the VAS scoring system, and any complications are evaluated by the SIR complication grading system. So it is done for all patients for documentation and validation of the fiducial placement related complications. Now, many times we see that some unusual presentations for after the fiducial placement, like in these patients, we have put a fiducial in the liver and it has gone into the pelvis. So when you do a assessment, post-fiducial assessment scan, usually we take the whole abdomen to see that the fiducials are in the appropriate place and it has not been migrated into the abdomen or any part of the body. Now, fiducials can cause artifacts. So MAR is important to do the post-fiducial scan, and scans need to do an MAR. Rigid registration is difficult because rigid registration does not cause matching of the contrast CT scan and the post-fiducial plain CT scan, which is required for planning. But deformable registrations are critical to match the liver volume appropriately in the contrast scan and the plane scan. And after the image fusions, it is much more appropriate and to define the target and treat it appropriately. So deformable registration is critical in liver treatment to appropriately delineate the target and treat it appropriately. The most difficult part of treating a portal vein thrombus is the contouring, because there is no appropriate guideline and there are a lot of uncertainties in contouring the portal vein. We have done a interesting and small study where our radiologist, radiation oncologist, and gastroenterologist have contoured the portal vein, and there is some agreed volume, there is a non-agreed volume, and the agreed volume by more than 4 of the six people who have contoured, we considered as the volume to be treated, whereas non-agreed volume, if one or two of the participants have done, we consider as non-agreed volume, and there is a protocol for the agreed and non-agreed volumes what we have planned, and this it may be an important guideline which can help us to define the contouring for the portal thrombosis and standardize the contouring system. Now, planning is standard done by in our system. It is done by multi-plan planning system with CyberKnife and delivered with the CyberKnife system. And the standard normal tissue constraints criteria are taken care of during the planning and plan evaluations. In the response assessment, we see a proportion of patients have a complete resolutions, and there can be bland thrombus, there can be partial thrombus resolutions, and there can be cavitations formations. So different kind of response to radiation can happen in the portal vein thrombosis. Now, in terms of toxicity, we know that in all the literature, the radiation-induced liver disease after SBRT happens in 15 to 25% of the patients. In our patients, 19%, especially 18% of the patients had a radiation-induced liver disease in our patient cohort. Many times we see something little different like this. This SBRT was done for the SCC, or it was done for a 24-grade single fraction, and which is very close to the rib. And the patient was controlled, disease was controlled, but at 8 years follow-up, we can see there's a rib fracture and the radiation changes in the skin. And that is unusual, but it is also seen in some patients. Now, when you compare the different kind of treatment modalities for portal vein thrombosis, we have seen that outcome is almost similar from surgery, with thrombectomy, nivolumab, and SBRT. But if you see the complications, which is around 18% of non-classic radiation-induced liver disease in this SBRT arm, whereas it is 30 to 35% grade 3 toxicity with nivolumab and with thrombectomy also, it is around 40%. So SBRT for portal vein thrombosis may give a comparable outcome like surgery, like thrombectomy, but the complication rates may be much lower compared to the surgical or aggressive approach. So to take home, in SBRT, we preferably real-time fiduciary-based tracking is required. Image guidance is mandatory. Respiratory tracking is required. High-volume centers are important because of the contouring uncertainties, tracking uncertainties, and treatment uncertainties. Volumes need to be done appropriately based on the CT and MRI, and there has to be deformable distribution need to be done. Dose preferably more than 100 gray BED should be done. 45 gray in 5 fractions equivalent dose may be appropriate in center, but higher dose of fractions are preferable. Constraints, standard constraints need to be followed, and toxicity is based on the radiation-induced liver disease criteria and change in type scores, which is done in most of the time, and response is based on the triple phase CT scan. So SBRT for portal vein thrombosis is a definitive option for those patients who are good performance status patients with preserved childhood score, and those patients who are expected to have a response to treatment. Thank you very much.